The the guidelines that came out recently that actually put NOACs, or they're often referred to as DOACs now because they're not so new. The D is for direct as opposed to novel, direct oral anticoagulants. With them now being preferred over warfarin, I think that makes the whole proposition of anticoagulation much more palatable. So it used to be that when a patient was defined as having an appropriate risk profile for AFib to be anticoagulated, there was the whole introduction of the concept of the vitamin K antagonist, warfarin, and what that would mean in terms of what the patient needed to do for their diet, the follow-up that they would need in terms of finding the right dose, getting their INR checked periodically, and that was arduous. And I think that contributed to a large part of the relative lack of uptake for anticoagulation. The biggest and best studies that have looked at this have reported that the rates of compliance with anticoagulation among people who are appropriate for it related to AFib is on the order of 40%. So most of the people that have AFib and should be anticoagulated aren't being anticoagulated. And so now that we have the direct oral anticoagulants that don't have the interactions with medications and foods the way that warfarin did, that don't require the monitoring periodically and the dose adjustment, that the proposition of being anticoagulated is a little bit less daunting for patients. It also means that for physicians that are managing anticoagulation clinics, the burden on the health system with regards to setting up the monitoring, figuring out the dosing, and the medical legal aspects of that have fallen away a little bit.